from BPH in the United States, costing about $4 billion a year. And about 52% of men say that they are avoiding treatment, a hugely common issue affecting 80% of men over 70 years of age. So just opening remark, there's lots and lots of microinvasive techniques to sort out BPH. Everything I'm going to present to you is when compared to TURP. So there's little or no significant evidence comparing to the other newer microinvasive techniques. So there's Urolift, Rhizome, aquablation, laser enucleation stents. These are just some of the ones I found I know little or nothing about, or aiming to do really the same thing, open up the urethra in a microinvasive manner. So just regarding prostate artery embolization, this has been around, well, first a case was actually done for hematuria, reported first in 20 years ago, and subsequently 2010, Cannavale did the first cases specifically for urinary retention. He's done a huge amount of work, Francisco Cannavale, in Brazil, and he has really been the main proponent of this procedure, teaching most of the guys who, went on and did a lot of the work. 8 years later, so that was 2 years ago, NICE approved the procedure for safety and efficacy. And just to mention, NICE is hugely biased towards economics. So it also requires those procedures that to be effective and safe must also show that they are economically viable or cheaper than the alternative for the NHS. And I think that's significant for us too. So there's lots and lots of evidence, prospective cohorts, retrospective cohorts. The PISCO has got 1,000 patients reported. He's showing 89% short-term success and 82% mid-term, 79% long-term success. There's randomized controlled trials compared with TURP and meta-analyses, and that's really what the basis of the NICE decision is, that they felt that there's significant evidence to make a recommendation. So the bottom line as regards the NICE recommendation and PAE versus TURP is we think it fits somewhere after medical therapy fails and before you go for surgery, that being TURP. So it's probably not as effective as transurethral resection, but it's hugely less invasive. So in this sort of BMJ little extract, they showed 50 patients in each group. IPSS at baseline was 19.38 in the PAE group and 17.59 in the TURP group, and they both had significant change in the IPSS score, although it was better with the TURP group. So what PAE aims to do is shorter hospital stay, so you can do a discharge the same day or the next day. It's minimally invasive, there's less complications, the return to work is quicker, sexual dysfunction is quite significantly less after PAE, and there's no post-operative catheter. I just want to go through the ideal candidates and a poor candidate. So it's generally used prostates over 40 grams. Patients must be symptomatic. IPSS scores of greater than 13 to 18. Decreased urinary flow, Qmax less than 12 to 15, or acute urinary obstruction. And patients who wish to preserve sexual function, and patients with comorbidity. So sick patients will tolerate a PAE possibly better than surgery. Poor candidates, patients not going to do that great. These are patients with chronic renal disease, GFRs of less than 45. That's really related to the contrast that we need to use. Vasculopathy, severe atherosclerotic disease that would block our access to the target arteries. Need for immediate results. So a TURP obviously removes tissue. It's immediate clearing of the path. That's not how PAE works. It takes a bit longer, probably 2 or 3 weeks. Very small prostates with probably median lobe issues, these are not going to do that well. So exclusion criteria would be patients with malignancy, because we're not taking any tissue away, renal insufficiency where we would damage the kidneys, large bladder diverticuli, bladder stones, neurogenic bladder, urethral stricture, obviously that would, we're not helping that at all, UTI and prostatitis, we can cause quite severe issues. The complications reported in this procedure, so the ROPE trial 2018 reports the UK, they had 17 sites in there with a total number of 305 patients, 216 underwent TURP, apologize, I've just gone backwards, 216 had a TURP and 89 had PAE. They report as complications of transient urinary retention, rectalgia. So this is related to non-target embolization and self-limiting hematuria, self-limiting hematospermia. So all of these issues sorted themselves out. Rarely they had a patient with UTI, proctitis, hematoma. They didn't have any life-threatening complication and any complication with self-limiting. There was, importantly, a couple of cases of ulcer or rectal ulcer, these non-targeted and embolization, so ulcer on the penis and ulcer on rectum, very rare, but they went away by itself. So just to mention, very large prostates also respond to prostate embolization. This is a trial from Russo. They did 80 patients and half of them had a PAE. Sorry, I apologize. There were 18 in each group. 80 had PAE, 80 had total prostatectomy. Not surprisingly, the patients with the prostatectomy had lower IPSS scores, lower peak residual volumes, and lower PSA and greater Qmaxes at 1 year. However, the PA was obviously less complicated, so that, short hospital stays and low bladder catheterization. But the most important thing here is that the complication rate, the PAE group had complication rates of 8.75 and the prostatectomy 31.25. So this procedure can be well used in large prostates. Just whip through the anatomy. So what I'm trying to say here is that there's a huge variability in prostate artery origin and a lot of anastomoses and where it's coming from. So there was an attempt to sort of classify these into groups A, B, A to D. The largest group has a supraglutial artery and a gluteopudendal trunk, which is this picture here. And that's compromises like 60 to 80% of patients. Our life is made hugely easier by something called cone beam CT, and I'll show that to you, where we can identify exactly the target organ of the artery that we've selected and make sure that it is in fact the prostate and not the rectum that we're embolizing. What we do, just mention, we go through into the prostatic artery. Our aim is to exclude any rectal branches that may be coming off, lower middle rectal arteries specifically, and the vesical arteries, and then just target the arteries going to the prostate, left and right, importantly. That's an angiogram, prostatic artery, and you can see some arteries going off lower into towards the rectum can be excluded. So just why we do imaging before the procedure is really to give us either anatomy of the prostate or a good idea of the roadmap that we're going to be dealing with. These patients are generally, in their 70s, their arteries are reasonably diseased, and so the pathway can be obstructed by a thromba. A CT angiogram is often requested. The downside there is we're giving a dose of iodine and radiation. It gives exquisite anatomy of the vessels, and that does reduce procedure time and radiation dose eventually, and that's really why we would do that. It isn't 100% necessary now that we've got cone beam CT. The MRI has advantage of no radiation. We do have to give contrast gadolinium. It can give us good anatomical knowledge, although the field of view is much smaller than on the CT unless you do extended study. And you can see the prostate beautifully, identify risk for malignancy, and so both have their purpose. The prostatic arteries are to be, it's quite challenging to get into because it's a very small artery and the anatomy is very variable, and there are quite a few anastomoses. So just things that the radiologist needs to know is to identify the artery. The commonest variance is middle rectal artery anastomosis, arising from prostatic artery, and we're seeing that in quite a number of cases, a third of cases. Anastomosis with the internal pudendal artery, contralateral prostatic artery, that actually helps a little bit because you get good flow. Basically, blood coming from the opposite side is pushing those particles deep into the prostate. And then anastomosis with the vascular artery, which we'd want to avoid. So ways to deal with this is cone beam CT. I've been mentioning this quite a few times. I'll show you a picture. It's basically an on-table CT scan. We use the same angiogram machine. It just has a function whereby we get a on-table CT or virtual CT. Microcatheters are routinely used in these cases. These are very, very thin catheters, much thinner than we're using, say, 7 or 8 years ago, and they allow us to gain access into these tiny arteries. Coils are great. These are literally little metallic springs that come out of the catheter, and we can isolate off an artery that we don't want particles to go into. So though we are technically blocking the artery that we don't want to block, because the coil is sited in that artery, those little particles don't go off there and therefore doesn't cause a problem. So we would routinely be using coils in sort of middle rectal vesical arteries. The little capillaries continue to feed the target organ while the particles don't reach there. Radial access is relatively new. This is where instead of going through the groin or femoral artery, we go from the radial artery of the wrist. It changes the angles, so we're coming in from the top. It opens up angles and really does make an easier procedure. The downside is tall men. Our catheter is a little bit short at the moment, although new ones are coming out this year. That'll give us access, that just give us another 20 centimeters, and we can get into those arteries from the wrist. So this is a picture of our angiosuite operating in this picture at UCT Private. It's essentially using fluoroscopy as the imaging modality. Patient is sedated by anesthetist under conscious sedation, midazolam, fentanyl, some propofol. The axis is, as you see, from the left arm. So the patient's arm is outstretched towards the right of the picture or the left of the patient. The big screen in front of me, I'm operating there with Maya. I'm on the right, Maya's on my left, is in front of us, and so we can see exactly what's going on live, real time. The advantages of the radial access is post-op ambulation, so they don't have to lie flat for 4 or 6 hours with a compression bandage on their groin. They can get up right away because they have a little bracelet pushing on the radial artery for 2 hours. So it's literally a little Velcro band with an air bladder on it, which we deflate, and that just pushes on the radial artery for 2 hours and thrown away. So the patient can get up and urinate. It's a shorter procedure just because of the angles, and said to give greater technical success. So the patient theoretically can be discharged as soon as they can void. There's no need to stay in hospital because it's not particularly painful. They can go home with antibiotics and non-steroidals. These are the kind of pictures that we're getting. I've taken these off an article on the internet, but essentially what we're doing is we're getting into the pelvic vessels. First picture, you can see internal iliac artery branches. Prostatic artery and obturator artery are labeled, and we do this at a slight angle. You know, if your oblique is ipsilateral, contralateral, this change view quite dramatically. They're little mnemonics to kind of identify the artery. The prostatic artery generally has quite a wavy sort of shape and parallel to the pudendal, but the rectal artery can look very, very similar. When we're in this, so this is a large catheter that's given us this view. We've injected contrast and taken the picture. Once in this little artery with the microcatheter, so this is the larger catheter directing a smaller microcatheter, which is in the target artery. We can then inject contrast, and then we can do something called a cone beam CT. So this is contrast injected slowly. That angiographic machine, which I showed you before this one, actually spins 360 degrees. So this head turns on an axis, and it gives us a virtual CT. We can confirm definitely that this is the prostate that is enhancing, this half, left half of the prostate. And we know we're in the right place and there aren't any anastomosis to non-target organs. When we're inside there, we inject particles. So this is, no one's really agreed what's the perfect size of particles, but it's generally thought that 300 to 500 microns is the right size. If you go really small, you risk necrosis and non-target embolization. If you go too big, you're going to have clumping of particles too high up. So generally in that range, 300 to 500 microns is what most experts would use. And there are a range of products. They all effectively block the artery. These are a gelatin sphere. You get a synthetic polymer, and they, said to go slightly deeper. None is proven better than the other. Effectively, they're mixed up in a contrast saline mix, and then injected into that little catheter that's in the prostatic artery, giving these little droplets that stay there forever. So these particles stay inside of the prostate forever. If you were to do a biopsy, you'd actually find little particles sitting in the arterioles. They don't go to the capillaries, they just sit on the arterial side of the vasculature. And then lastly, just to mention that finally it's funded. We've got a limited, although quite a large number, agreed to a pilot. It's across South Africa. So it's offered by radiologists in Cape Town, Joburg, and in Durban. All have been trained in this procedure. This is discovery funded. The other providers do fund it and have funded it in limited ways. So we need to motivate. But effectively what I want to see is, can we, is this viable? So inclusion criteria, patients over 50, prostates over 60 grams, moderate to severe low urinary tract symptoms, refractory to 6 months medical therapy, patients with sexual dysfunction not accepting risk of sexual dysfunction, that's from TERP, IPSS is significantly increased, greater than 18, quality of life greater than 3, Qmax less than 12. So these are the selection criteria, and acute urinary retention. Patients with high surgical risk would also be included. Exclusion patients with malignancy, neurogenic bladder, diverticular stenosis, and advanced atheroma. That would limit our access and non-visualization prostatic arteries on the CT. So what we're trying to do is just make urologists aware that this is an option. It lies in your arsenal. except there are lots and lots of microinvasive means to treat BPH nowadays. We've just managed to get this one sort of through the hoops. Thank you very much.
Hi, Gary. I hope you can hear me okay.
Yeah.
Just to say thank you very much for a superb talk. Thank you very much for introducing this to us across South Africa. I wonder if there are any questions. I can open it up to the floor if anyone would like to raise their hand. I'm just looking at the various participants to see if anyone's got a question. Can I ask a question, Gary? It's truly astounding for us as urologists to see that you can do this through the wrist. It really is wonderfully astounding, minimally invasive technology. I suppose we're bound by our guidelines to some extent as urologists, and the American Urology Association still regards it as should only be taking place within a clinical trial. How would you respond to that in the sense that they're making quite a strong statement there about where they see it in the experimental terrain rather than something that's proved? They point to the heterogeneity of the data that's available and some of the concerns about safety. Do you think that's warranted, or do you think that is turf protection from us as urologists?
Look, I question one. NICE is a pretty stringent body. It's very hard to get things through them without enough data, and certainly from a safety perspective. My question really, when I went through your other options, I mean, there's a really universe of microinvasive options in the United States. Are those available across the Atlantic and here, and are they funded? So my question is, there's a lot of competing technologies. They may well be safer or better. I've no idea. I don't know what data supports them. I'm really comparing to TURP. So would it be reasonable to say, I don't know when compared to other less invasive technologies, but I think against TURP, we've got very good data.
Thank you, Gary. I'm just looking for, are there any other questions there? I suppose the other concern would be that papers have suggested that 25% of people undergoing this procedure would end up with acute urinary retention after the procedure, which seems quite high. Would you agree with that figure in your experience? And as a second question, I presume Discovery is wanting you to do a data audit of the patients that have been done, or is that not part of the agreement?
Yeah, so the second question, yes, they do want us to do a data audit of our success and complications. They would like us to report to them. As regards your retention, it is a issue. The number I quoted, I think, was 18%. I think, to be fair, every patient with a TURP will get a catheter. It is that you're not going to. It is less than that, but and it does go away, and it's I don't see it as a major issue in the fact that it's there for about 6 or 7 days at the most, and then you take it out as a trial. We would let them urinate with they can't. We would put in a catheter, we take it out, they can't, then we're going to put it there for a week. But it is against TURP where everyone gets a catheter for a few days. So I don't. Do you see that as an issue?
No, certainly we would have certain patients who would have prolonged catheterization. So for certain, sure. The other thing, post-prostate artery embolization syndrome, is that something that you've encountered? Use of contrast, etc.
Yeah, so you do get it. Embolization, I mean, it's well documented. We're seeing it much less these days. So you could have a transient fever, you've got pain. you know, you generally just treat with, you know, paracetamol and be aware of it. It's not a, we haven't had any major issues recently, or even anaphylaxis. I don't think I've seen for about 4 years, even anaphylactic reaction.
I suppose the other question that urologists would probably want to know is the maximum size that you're happy to treat. You prefer bigger prostates, which is good because prostates surgically managed are more difficult when they get bigger, and you have to use things like laser or open procedures. You're happy to treat prostates bigger than 100 grams?
Yeah, I mean, having read that article, which showed really good results. I mean, so traditionally we'd go sort of 40 to 80. The discovery is said greater than 50, and you know, I don't know if it's 45. I mean, if the patient's symptomatic, I think we should go for the central compression. But I'm pretty excited that we, you know, got great results over 100. I think it's worthwhile. I don't really see a downside. I mean, you can always go step it up to a surgical procedure. If you get away with this, then, you know, you've got all the benefits.
I think one of the criticisms apparently of the procedure is that you're targeting the whole prostate as opposed to many of the other procedures which are targeting the area of the prostate that's causing the bladder outlet obstruction. And that's presumably part of the mechanism of why there might be treatment failure. Failure in the cohort that you've been doing, has that been a big issue? Patients that I've had contact with that you've done have been very happy, and the side effect was having to wear the wristband. So, astoundingly, has that been your experience, or have there been a few that have run into some troubles?
So I think failure is more technical failure than procedure failure. So it would be my failure to get into the target artery, or failure to inject enough particles into the target artery, because you get a little bit nervous when you can't see where these tiny little particles are going, and if you are spilling into penis or bladder or rectum. So I think you've got to separate technical success from clinical success. And certainly when you're starting, you might be overzealous, and then, you know, you go through phases. So I think there is a curve. We also fail to get into both arteries sometimes. You need to embolize the left and the right to have good clinical effect. And the problem is these tiny little arteries and their angles and atheroma might make it impossible to get in. So there definitely is a group of patients we just can't get into those arteries, in which case we'll do unilateral and hope for the best. But, you know, I think in the experienced group, you know, Pisco, look, he's done 1,000 cases. I think I've done about 10 or 15. So we're not even close. But he's reporting sort of 82% success rates in medium term. So I think it's extremely good.
Hi, Prof. How are you? I also just wanted to add, so, you know, we've had a few cases where, so it is obviously a lot easier to get into the bigger arteries. So the bigger prostates will generally have larger arteries feeding them. So it's a lot easier to get in. With the smaller ones, you know, below 40, the arteries are a lot smaller. So, you know, that obviously increases the radiation time, and it just you know, we have to obviously weigh up the advantages versus the disadvantages. We have had, I think, 1 or 2 cases where we've done just a unilateral because we just weren't able to get into the one side. And the studies actually show that, you know, there is improvement in the symptoms even if we just do unilateral embolization. So it's in the range of about 40 to 50% of, you know, reduction. So it's obviously not the ideal situation, but it will improve symptoms to a certain extent. But I think certainly the larger prostates are easier to get into. The other thing that I wanted to also mention, which was quite an interesting space in prostate artery embolization, is there have also been a few studies which there's increasingly more research into prostate artery embolization and small prostate cancers. So it's quite interesting. The study that I was reading last night, they actually showed that so following a prostate artery embolization and then a subsequent prostatectomy, they found that 20% of the cancers were entirely treated. They weren't able to find any evidence, so it had necrosed. So I think that's also an interesting space for the future. I think it's really sort of early, but it's just something to think about as well. So I think, because the other consideration is patients over the age of 60 and 70 may have underlying occult malignancies that may or may not exclude them from PAE. And I think that's the question that they're now sort of saying is should we be excluding those patients with the smaller malignancies? Anyway, that's my 2 cents worth.
So can I just add, just regarding the difference in the US and Europe, I think has a lot to do with the economics. So in France or the UK, Germany, there's a bias towards urologists doing less invasive therapy. They're happy to hand these patients over to the interventional radiologists for prostate embolization. We certainly see that at the international congresses. They're getting quite a lot of referrals. I think the US, they're competing a lot more, for their their cases. And so you get these interventional sites offering prostate embolization. And it's all a matter of flow. I think a lot of it's relatively political. The other thing to mention is, this whole idea of sexual dysfunction after intervention, in my opinion, is quite a big issue. We don't see it reported that much in the trials, particularly not the meta-analyses. But when looking, there's a big difference when compared to TERP of retrograde ejaculation, erectile dysfunction. And I think it's an important thing also for us to acknowledge that less invasive therapies have that advantage.
Gary, thank you very much for that comment. I see we have one question from Vishan, who's typed his question, and just surely there are a few other questions for our colleagues. Very nice opportunity. These experts give us input. The question is, does make surgery more difficult later? Gary, what do you think?
No, I really don't think so. There's no evidence for that. It probably make it a little bit easier, less bloody. I can't see how it would be a problem. It can make it a little bit more mushy, maybe a little bit more sticky, but you're not really nucleating anything out of a capsule. So I don't think so. I haven't seen it reported, but to be honest, I haven't had any patients personally going for surgery afterwards.
Sure. We have Professor Mutambriwa from Sipaka Makato Hospital.
Thanks, John, and great. Thanks, great talk, Gary. It's it's given us some good insight. My only question is that on one of the issues with the embolization is the fluoroscopy time, because apparently the amount of X-ray of radiation that's going there, and we know it's a lot and everything. How much radiation is really are the guys exposed to during the procedure?
The patient or obviously the operator. I think you're absolutely right. It can be a lot. I'll justify it in saying it probably doesn't matter that much in a 70-year-old male. It does affect us, the team. We will stop after thresholds are reached. So what we do is, in order to, it's a hugely important point. In order to reduce that, we pre-op planning. So a CT scan gives you a great idea of exactly where your target is. That's going to reduce your dose. If you're doing lots of cone beams, your dose flies, goes through the roof, and obliques of the pelvis are very high dose study. So you're absolutely right. This procedure could take 3-4 hours, and if you're screening all the time, you are going to be creating an absolutely massive dose. So you do need to have some experience in handling microcatheters and knowing what the target is and where you're going wrong. You make extremely good points. I would think average procedure time for this procedure would probably be around 1.5 to 2 hours, maybe 20 to 40, 30, 40 minutes of screening time. Compare that to uterine embolization is under an hour and about 10, 15 minutes of screening time. So it's probably double. But the anatomy is, it's a 30-year-old female versus 70-year-old male.
Gary Meyer, thank you so much for your contribution this morning. You've certainly educated us a great deal, and just to know that it's available in the 3 big centers.
Yeah, be happy to discuss any time in the future. I wanted to know how we go exactly as our cases accumulate.
Gary and Maya, we normally give out a nice bottle of claret, but we can't do that virtually. But I understand that we're very grateful for your input.
We send love.
Thank you very much.